All right, welcome everyone. Please grab your lunch and take a seat. We're about to start our session. This is called Unleashing the Potential of Perioperative Immunotherapy in Resectable Non-Small Cell Lung Cancer. This is our faculty. I'm Jessica Donington. I'm a professor of surgery at the University of Chicago. I'm joined by hopefully illustrious colleagues that you are well aware of, Dr. David Harpole, professor of surgery from Duke University, and Jonathan Spicer, associate professor. I thought you were like the emperor up there in...
No, I'm just a worker bee.
But associate professor at McGill. So some pretty strong expertise sitting next to me on the use of immunotherapies in resectable non-small cell lung cancer. I want to thank both our in-person and our virtual attendees. So for those in the room, it is important to know that we have a live but virtual audience with us. So when we do questions and answers at the end, I really need to insist that you go to a microphone or they're just going to be listening to nothing. PeerView is providing this educational session. AstraZeneca, Bristol Myers Squibb, and Merck have been providing the educational grant to support this session. If you haven't done so already, please complete the pre-event survey on your iPad. Please participate in the audience polling throughout this program. It's a very important part of it for PeerView. And submit any questions you have through the iPad. At the end, you can also go to the microphones for the Q&A, but if you think of questions as we go, type them in and we can address them at the end. You can review the materials from this session at peerview.com under the tab Non-Small Cell Lung Cancer 2023. So our goals today is to enhance your understanding of the latest evidence supporting the use of neoadjuvant and/or adjuvant immunotherapy in resectable lung cancer patients. We also want to augment your skills at identifying candidates for and integrating neoadjuvant and adjuvant therapies and individualized treatment plans for patients with resectable non-small cell lung cancer. So I think we'll start. So it's kind of surprising that we haven't seen this slide yet as part of this AATS session. And it is the new guidelines for multimodality management of lung cancer and the expert consensus guideline from the AATS. And what I really want to highlight is that central message that the management of patients with early stage lung cancer is evolving. I hope that everyone recognizes that from this meeting. But more importantly, that thoracic surgeons should be aware of recent neoadjuvant and adjuvant trials and should lead multidisciplinary discussions. We really need to be at the center of these treatment decisions, and that means we need to keep abreast of the evidence. So the plan for this session is to start by reviewing those trials which have led to regulatory approvals here in the US. That's the neoadjuvant Checkmate trial, and then the adjuvants IMpower and Keynote trials, and then look at the 3 peri-adjuvant trials which were reported earlier this year. So I don't want to say that this session is a review and a quiz for all of you to see if you've been paying attention during this 2-day symposium, but it might be a little bit. So I'm going to invite Dr. Spicer up to review the neoadjuvant immunotherapy evidence.
Okay, this will be quick because I hope you've all heard this before a million times, but I still think it's worth reiterating it, and there's always little pearls that we pick up along the way. So here you have the 3-year update that Dr. Ford presented at the European Lung Cancer Congress this past spring. And you can see that we have a durable improvement in the event-free survival. I think this is important to pay attention to because with other types of therapies, for example, with targeted therapies, there was some concern, particularly in ADAURA, as the treatment ended, that perhaps you might have more recurrences. And what we see here is that short course of treatment, we're talking about 9 weeks of preoperative therapy, 4 or so week break before they get operated. So within about 12 weeks, the patient has completed all their treatment, and then they go on to their life, which is, if they're cured, that is a true definition of cure, meaning that they're not getting any treatment. And so I'm very excited to see these outcomes continuing to be sustained 3 years out, and we'll see if it goes on to 5 years as we wait. And what we're seeing is really an effect that's happening systemically. So this is time to death or distant metastasis. We know most of our patients who recur distantly will ultimately die of their disease. And so that short course of treatment, and I think it's worth it for people to look at the iSaber trial, where patients receive just 4 cycles of immunotherapy with SBRT, and you're seeing improvements in EFS in that context. Well, it doesn't necessarily take a ton of treatment to affect a very powerful impact on this, whatever systemic micrometastasis might be present. And of course, this is what we're all aiming to achieve for our patients, which is an overall survival benefit. It's important to remember that Checkmate 816 was a relatively small study with only about 350 or so patients. So the statistical power to detect overall survival benefit from a statistical perspective is somewhat limited. That said, there's still a sort of, I think, clinically important 14% gain in overall survival at 3 years, and a lot like the EFS is sustained as time goes by. These are the outcomes for patients who either got chemo-nivolumab or chemo alone in those who received surgery, and you'll see they look reasonable and similar to the whole population, since it was only about 16 or 17% of patients who didn't go on to get an operation. And you can see these curves are much more frightening for those who do not go to surgery. So good news, it's important to have an operation as part of the regimen here. I think that's important for our practice, and it's important for us to support our patients through the preoperative therapy to get them to the operation. Just to understand these curves, if you look at the top left corner, the EFS, one of the events is not going to surgery due to progressive disease. So that's why you see that sharp drop-off. This isn't necessarily patients dying. These are at 3 months the patients who did not make it to surgery. So by definition, it's an event, which corresponds to this specific group of patients that we're looking at here. And so that's why I think more valuable curve is to look at time to death or distant metastasis. And it's interesting that despite not getting surgery, those patients who received chemo-nivolumab have a longer time to death or metastasis than those who got chemo alone. So it's the way I interpret this is that patients can be salvaged despite not going to surgery with forms of local therapy or escalation of systemic therapy. And it's also important to understand that these patients who do not go to surgery are patients, for a good proportion of them, who are progressing on our most aggressive form of systemic therapy, so they will not perform well, and they shouldn't really be compared to Pacific, because we know, for example, that patients who are PD-L1 negative in Pacific will do poorly and probably don't get a whole lot of benefit from that adjuvant durvalumab. So you have to understand that these are a biologically aggressive group of patients. Again, I'll reiterate that most of the benefit of chemo-nivolumab is being affected distantly. You can see a reduction by half from 22% to 10% distant recurrence, but not so much on the local regional front. So no real important difference in the local regional recurrence, and that speaks to the importance of doing good surgery, getting that highest lymph node resected and hopefully benign, and getting good margins on your patients is very important. So quick polling question here. Which of the following accurately describes the findings based on the 3-year update for Checkmate 816? 1, long-term improvements were seen in event-free survival and time to distant metastasis or death, but there was no indication of improved overall survival with neoadjuvant nivolumab plus chemotherapy versus chemotherapy. So this should be a gimme. 2, long-term improvements were seen in EFS and time to death or distant metastasis, as well as an encouraging trend towards improved overall survival with neoadjuvant nivolumab plus chemotherapy versus chemotherapy. Or 3, I'm not sure. So you can go ahead and enter your responses. I think that should be, that's plenty of time. You should have gotten it by now. So looks like most folks are getting this correctly, I think.
And they learned. And they learned.
And they've learned, yes. Very good. Okay, Dr. Donington.
Thank you. So now we are going to move on to adjuvant immunotherapy, which is actually something we haven't discussed a ton at this meeting, but something that hopefully you are familiar with. So this is the Empower 010 data presented by Heather Wakely almost 2 years ago now at ASCO. Patients in this trial were completely resected, went on to 4 cycles of adjuvant cisplatin-based chemotherapy, and then were randomized to a year of atezolizumab or not. These were the early disease-free survival curves. And you can see that in the primary study population, which is the first curve you see there, for those with a PD-L1 greater than 1%, stage 2 or 3, we see a significant improvement in overall survival. As they broaden the population to include all randomized patients and the intention to treat, we still see an improvement, but not as robust. And therefore, the regulatory approval for this was based on that first curve. I know this is a busy slide with lots of Kaplan-Meier curves, but let's kind of dwell down to what's important and not important here. One is the inclusion or exclusion of EGFR and ALK patients. We know that EGFR and ALK patients can have PD-L1 positivity, and they can respond to these medicines, but it is important to note that they respond to their targeted therapies much better. And therefore, we have really begun, or not since these trials were designed, to exclude these patients. The other thing that's important to note about EGFR and ALK patients is that it's not easy to switch from an immunotherapy to a targeted therapy because of the risk of pneumonitis. So really, since this trial was designed, we have now worked to exclude those patients. So really, those top 3 curves are where the focus would be. So again, the first curve shows you all patients 2 to 3A who are PD-L1 positive, and then we look at those who are low expressors, 1 to 49, and then the group where the response has been the most robust, the high expressing group, PD-L1 greater than 50%. I will tell you, in Europe, that is where the approval is, and they do not give adjuvant atezolizumab for those with PD-L1 expression 1 to 49. Next, this brings us to Keynote-091, or the PEARLS trial. Got a little less press here in the United States, I think, as opposed to the atezolizumab. It was a trial which was primarily run, I think almost entirely run in Europe. Had slightly different inclusion and different endpoints, but was otherwise very similar. One difference between PEARLS and Empower 010 was that this trial did not require platinum-based chemotherapy. It was encouraged, but up to a quarter patients in this trial did not see them. This was the overall survival curve for that trial, and it does mimic the atezolizumab trial looking at the same group, meaning all patients who are PD-L1 positive. We see a pretty real separation of those curves with a hazard ratio of 0.76. One issue with this trial, and why people are, I don't know if the word would be frustrated as much as scratching their heads, is that another endpoint of this trial, which seemed like it should have been a slam dunk, was that they would see an overall, a disease-free survival benefit in the high-expressing group. And they didn't see that. As you can see, a crossing of those curves at about 18 months. And the only explanation we have for this is that the control arm performed exceedingly well, but it has really always been a mystery as to why this group did not perform as well as we see in other trials. And in that sense, this is a bit of an outstanding finding. There are at least two ongoing trials that are still have yet to be reported. One is the ANVIL trial through this alliance, and then the BR31 trial. ANVIL looks at the addition of nivolumab, and BR31 with durvalumab. Otherwise, quite similar with some subtle differences in their design, and hopefully we will start to see these results soon. So we're back to an audience polling question. Which of the following accurately describes the current evidence for adjuvant immunotherapy in resected non-small cell lung cancer? Both atezolizumab and pembrolizumab has shown a disease-free survival benefit in populations with PD-L1 expression greater than 50%. Both atezolizumab and pembrolizumab have shown a disease-free survival benefit in populations with no tumor PD-L1 expression, or both atezolizumab and pembrolizumab have shown a disease-free survival benefit in their overall study populations, or you're just still confused and have no idea. Please vote. Ah, beautiful. Not only did you get it right, I hope to impact that. Thank you very much. Can we go back 1 second? Oh, no going back. Okay. Well, we still have some people who thought that, the PD-L1 greater than 50% for both trials. And again, that is a very important difference between those trials, is that we did not see that benefit in the high expressors for pembrolizumab. All right. We're going to move on now, and I think Dr. Harpole is going to take over on the peri-adjuvant trials.
So we're going to run through some more Kaplan-Meier curves. Which one is it? Here's. So this is an overview of the trials that we just saw. We just went through 816. We went through the adjuvant. I'm going to talk about the three sort of the perioperative trials. In other words, therapy up front, therapy out back, with the theory that giving consolidated immunotherapy as an adjuvant may actually increase the survival over time. So Keynote 671 was just published like a week and a half ago in the journal. We had heard their results previously, and it's neoadjuvant pembro plus chemotherapy followed by surgery and adjuvant pembro compared to just platinum chemotherapy. The interesting thing about this trial, the adenocarcinomas had to have pemetrexed and cisplatin, and the non-adenocarcinomas had to have gemcitabine and cisplatin. So it's a little different from 816 and Aegean in that there was a little more prescriptive chemotherapy, including carboplatin. But the EFS shows here that at 24 months there's about a 18-20% difference. The hazard ratio was 0.58 for the pembro arm. You can see that the major pathologic response and complete pathologic response rates were significant. The blue is the treatment arm with pembro versus chemotherapy in the orange brown. And again, there was a significant difference in both the MPR 90% necrosis versus path CR 100%. Aegean was a trial with a similar design with patients that had chemotherapy with durvalumab versus placebo afterwards, and durvalumab as consolidative therapy. You can see again a good 10 to 12% difference at 24 months. Note both Aegean and 617 are relatively immature. Aegean's at 1 year follow-up, and 671 is at 23 months. So both these are pretty immature trials, but they did meet both their criteria. And similarly for path CR and major pathologic response, 90% necrosis, you could see the blue panel, the treatment arm with durvalumab was significantly improved to the chemo alone arm. I just reviewed these data early this morning, so I'll go through it. I think it's important to note in all three of those trials, somewhere between 18 and 20% of the patients did not undergo a resection. And in that central bar for the Aegean trial, it was 40% were patients who progressed by radiologic criteria. About a third were patients who had adverse events and were not able to have surgery during the prescribed period of time, and then there was some refusal by patients at that point. But those who underwent resection, the vast majority were able to undergo complete resections. I show these easier. You can see in the lower panels, those who completed surgery, it was well over 90%, with the duration of surgery around 3.5 hours in both groups. NeoTorch is a China trial of another PD-L1 inhibitor, and you can see again their data. The trial was approximately 400 patients, so about half the size of 671 Origin, but again, a significant difference for the blue treated arm with major pathologic response and path CR rates, again, significantly better. It is interesting that the chemotherapy arm in this trial, I think it is performed a little bit worse. One would usually expect a path CR rate of around 5% for chemo and a major pathologic response rate around 15 to 18%. So I think that the trial's positive, but clearly the non-treatment arm was a little worse. There are some other ongoing trials that we just heard. The press release from 77T, it looks like it's met its event-free survival point. Empower 030 is, again, the paclitaxel, pemetrexed, gemcitabine, with or without atezo, and again, atezo as a perioperative. The Checkmate 77 is nivolumab with nivolumab or placebo as an adjuvant. And the last trial is the tislelizumab, again, with it up front and as an adjuvant. So, and this is just the press release that was from 2 days ago for Checkmate 77. So here's the questions. Which of the following is an accurate statement about the results reported to date from the phase 3 perioperative trials in resectable non-small cell lung cancer? 1, in all the trials, perioperative regimens involving neoadjuvant and adjuvant immunotherapy have shown statistically significant improvements in EFS and OS. Number 2, in all trials, perioperative regimens involving neoadjuvant and adjuvant immunotherapy have shown statistically significant improvements in EFS, but not OS. And 3, the trials have not shown statistically significant improvements in either EFS or OS with perioperative regimens involving neoadjuvant and adjuvant immunotherapy. And what the heck? Eric can say he doesn't know.
Wow.
You all paid attention.
Good job.
I'll pat myself on the shoulder.
All right, I think from here we move on to a brief case and some discussion, and then thank you for those who have put in questions. We have some really good questions to go through, so we'll try not to dwell too long on the case. So this is a patient of Dr. Harpole's, I believe, a former smoker, 20 pack years or 20 years ago, with pretty good PFTs for North Carolina with an FEV1 of 58 and a DLCO of 90, ECOG 1, asymptomatic with a 6-centimeter suprahilar tumor in the right upper lobe. Here is the CT and the PET, and we can see the large suprahilar mass and that PET positive lymph node in the paratracheal location. Patient underwent a brain MRI, which is negative. Nothing else showed up on PET. Underwent an EBUS. 4R7 and 4L were negative, but the 11R was positive, and they were able to biopsy the mass itself. It's an adenocarcinoma. So we have a T2/T3 based on invasion, and then N1 tumor. So a stage 2/3. What treatment would you recommend for this patient? I want you all to vote. 1, definitive concurrent chemo radiotherapy plus consolidation IO, i.e. the Pacific regime, neoadjuvant chemotherapy plus radiation, neoadjuvant chemotherapy followed by surgery, neoadjuvant chemo IO followed by surgery, or surgery followed by adjuvant IO. 6, I still don't know. Please vote. Patients like this, I do tell my patients when they come to see me that they could potentially go to 5 centers and get 5 recommendations.
Right.
And they may not be wrong recommendations. So I think that is something to keep in mind, but we all appear to be of a like mind here. So after hearing a lot about induction therapy, most of this room is in favor. So I'll ask you guys, what would make you not want to induce this patient? Are there patient or tumor characteristics which would drive you away from resection?
Well, for sure, a biomarker profile that shows a EGFR mutation or something, or ALK alteration would push me towards upfront surgery in this setting. But patient-specific factors, it's hard to argue against neoadjuvant. I think that the N1 node can be problematic and present a more challenging operation, but it's not a reason not to do it for me.
Yeah, I chose this picture because number one is a stage 2 where there's still some controversy on someone who's N1. This is not that. Would you do this? And then I also chose it because, as Jonathan and I were discussing earlier, a large right upper lobe tumor that's N1 or so forth is pretty much a slam dunk towards this approach. But this was a little bit more of a central tumor and is probably going to require a little more of a complex resection. And I think in a good performance status, these people are ideal to shrink this some and then be able to do a complete resection on, because I'm not sure an upfront surgery that you'd be able to do a complete resection on this patient. I don't, so.
Well, Dr. Lieberman showed us that. It looked like a piece of cake when he did it.
Well, I'll send them to Chicago.
So I think Dr. Spicer brought up a really important point, and there were 2 questions on the iPad regarding mutational testing and neoadjuvant or even adjuvant IO approaches. So again, the trials, when they were designed, did not always exclude patients with EGFR and ALK mutations, but in my institution, before we start on a checkmate regime, we always test our patients for EGFR and ALK. And if they have one, we actually don't go down the neoadjuvant regime. We will either resect up front, or if they're a 3A, we would just give them induction chemotherapy and then Adura, osimertinib on the back end. Any different for you?
Yeah, so there's also the PD-L1 level. One of the questions that came up is, and I missed what the PD-L1 level was for your patient, Dave, but as you may know, in Europe, PD-L1 less than 1% is not approved currently, and so that's based on the sort of lack of really strong proof that there's EFS benefit in that category of patients. We just recently finished doing a meta-analysis of the available phase 3 data, and there is statistically significant benefit to in the less than 1%, but it's of lesser magnitude than what you see for the PD-L1 positive patients. So I think that plays into some decisions, but not really. We will treat those patients.
Yeah, and I think it was a power issue in 816, and a GN with 800 patients. There is what you hope to find is a stair step of response from less than 1 to 49, and greater than 50, that they were all significant. I think it's more of an impact in the adjuvant setting because the data just aren't as robust, and I think that the indications for giving adjuvant immunotherapy, certainly PDL status, has a much larger impact.
Yes, it does feel a little counterintuitive that in the induction setting we are somewhat agnostic to PD-L1 expression, and we'll give it. We certainly are enthusiastic when the PD-L1 is high, but we do not stop if there's no PD-L1 expression. And yet in the adjuvant setting, all decisions change.
It is very confusing because you'd think that in the adjuvant setting you have a ground truth. You have the true PD-L1, the whole tumor has been resected, and we know that the expression is heterogeneous, and that's part of the reason why I will offer in the neoadjuvant setting even PD-L1 negative, because they may have biopsied an area that is negative, but the patient ultimately turns out to have. It's a bit of a confusing space, and I think the bottom line is PD-L1 is not a great marker. And with the neoadjuvant regimens, you're giving concurrent chemoimmunotherapy, which is a standard of care for the metastatic patients across those.
One thing I would like to ask the two of you, and it's not a question, maybe get a show of hands, is that these data have certainly made us adapt our regimen for what used to be, say, the straightforward 6 centimeter right upper lobe cancer that's EBUS negative. What are you doing? We've been pushing those people towards a chemo IO induction approach. I mean, in Montreal, are you doing that? In Chicago? If you have, what looks like a very large but isolated lobar tumor, or are you taking them to surgery? I don't have the right answer here, I'm asking.
There isn't a right answer. So we push toward induction, and I think I have 2 reasons why I do it. One is that scientific reason that I do think we get better T-cell clones and better, eradication of micrometastatic disease if we can teach our T-cells, about the tumor with the tumor in place. And I think the second reason is, and maybe it'll all change if we have perioperative approvals, 3 cycles versus, 13 cycles. Right. I think 3 is easier, and I think it's a really easy sell to our patients.
Yeah, and I think that the comparative morbidity of at least the 816 regimen is so much in favor of that versus that whole year, which comes with clear added morbidity, more patients on steroids, et cetera. So it plays into the decision making for sure.
I'm going to go to another one of our questions because I think it still plays a role in this case. Someone asked, what are your recommendations regarding holding or restarting IO before or after surgery? Is there a window that you like? Would you operate 3 days after the last cycle? What kind of window do you like to operate after IO?
So one of the interesting pieces of data we have is LCMC3, where the window to surgery after the 2 doses of atezolizumab was very short. It was within 2 weeks. And when you look at immune-related adverse events in that trial, there are actually more in the post-surgical setting than there were during the induction regimen. It's a short course, so it's rare to get really severe immune adverse reactions, and with just a couple doses it happens, but it's rare. So I like to wait a good month, and particularly in the context of chemo, I think you need a good 3 to 4 weeks before the marrow recovers. When there are complications, I just wait till the patient's ready. I don't feel a rush to take them to the OR. Certainly don't want to bring a frail patient expeditiously to the operating room when there might be other alternatives or more time to recover from the problems of memory.
And how long will you wait for someone who has a grade 3 or 4 immune-related?
So I have all my medical oncologists on text message, and we communicate about those patients. I think that's really important because during those times, the patient is really in their hands, and you have to be able to share, I think, how that patient is evolving. And I just had a discussion like that yesterday about patients on a trial and whether we should skip the 4th cycle and what do we do? Do we go to surgery? Do we wait it out a bit more and rescan, et cetera? So,
historically, I've always felt that, and I tell my patients that after, when we used to use neoadjuvant chemotherapy, that we have a 3 to 4 month window of where you're going to see the shrink. In fact, if you get continual scans, you would see continual shrinkage over that period. And so in a GN, it was 34 days, which in both arms, which is pretty reasonable. There were none done before 2 weeks, but I think Jonathan's point's taken. So around a month is what we do. But I don't hesitate to go 60 days on somebody if they've had a tough time, but you still think they're going to pull through. I call it the thumb test. I look at them and their experience of sticking the thumb up and looking at them. And because there is that separation of the patients who frankly were super debilitated from therapy, and we just know that frankly making that decision sooner as opposed to later and getting them into a radiotherapy protocol, a more Pacific type thing makes sense.
Yeah, we really struggle with our medical oncologists in that time. Once we kind of get to that 6 weeks and we say, oh, they're not perfect, we need a little more time, I can feel how antsy they are. We talk about our sphincter tone, I can feel their sphincter tone across the table at tumor board. And we say, okay, we'll look again at 8 weeks and 12 weeks. And it's hard for me to get them to not treat them past 12 weeks.
Yeah.
It's really a struggle.
I don't need the patient to be off steroids, but I need them to be down to maybe 5, 10 milligrams. So it's I think that's quite important, and I think you have to discuss the alternatives with the patient. And they have to understand that this isn't the end. If we don't go to the operating room, it's not a catastrophe. There are other ways to salvage their disease.
All right, let's see if we can move on with our session. I don't think we changed anyone's mind here. We were all pretty unanimous, but I'm going to ask you to quickly vote again after this illustrious conversation about how you would approach this position. Pacific with definitive concurrent chemoradiotherapy followed by IO, neoadjuvant chemotherapy plus radiation, neoadjuvant chemotherapy and surgery, a checkmate routine or surgery followed by adjuvant. I'm not sure, we only confused you with our discussion.
It's true, there is no right answer, and that's the other thing. You have to individualize. We're lucky that we have so many options, actually.
Isn't it, it really is amazing. There was not that long ago that this was pretty, oh my God, we got everybody now.
Yeah. It's difficult as a surgeon not to have a black and white answer on everything, and unfortunately, this is kind of the gray area for us, and I think we're having to learn, how to separate that into the black and white answer every time.
All right, so now I'm going to I think I can move from here, and we're in the question. Oh no, perfect. Case continues. So patient receives the chemo IO.
I think we've
We've gone all through this?
Yeah, we've gone through all this.
But I do have questions from this. So we're going to say the patient, oh my gosh, there's more. Oh no, this is perfect. Following surgery, for which patient would you consider adjuvant immunotherapy? 1, patients with past CR, 2, patients with persistent disease, both, neither, or I'm not sure. Oh, this will be interesting.
What was the pathological response? So
It's if they had this.
depending.
Yeah.
I'll read the question.
Which does go into our kind of next set of questions on the iPads about, would this be a good patient for adjuvant? So I think the most popular answer here is both, that we would consider adjuvant therapy, whether there is a past CR or persistent disease. I think this reflects my practice. I kind of push them all back to the medical oncologist and say, hey, go for it. And it's definitely at my tumor boards, depending upon whether you want them to receive adjuvant or not. I know exactly which oncologist to send them to.
Yeah, and we just got an access program. We have a TISO in the adjuvant space, and we have now adjuvant Pembro through an access program. And I can't get the medical oncologist to really say no, ever, because I think they're in that sort of defensive position of having therapies available to the patient, and it's hard for them not to offer it unless there's a clear contraindication. The patient's just not fit or doesn't want it. But the data is not super strong for patients under our practice, and where I really strongly recommend is greater than 50%. A TISO, there's an overall survival benefit, and it's not subtle. It's almost 20% at 5 years. So I really advocate for that. I'm less convinced on the other side.
And I think that the data on all of these trials needs to mature enough for the PCR question. That their survival is not 100%, and I always come back to breast cancer. They're unhappy with a 96% survival in the control arm, and they treat everything. So I don't think we should take a 30 or 40% relapse and death rate for somebody in the good arm of our trials. Maybe the ctDNA data that's connected to all these trials, maybe someone who is past CR and then goes MRD negative, that maybe we'd follow those people. I don't know, but right now, I kind of feel like we should be treating everyone with something.
With something, even the past CRs?
Yes.
Wow.
Well, yeah.
If you really scrutinize the Kaplan-Meier curves and you look at 816, it's about a year out that both the treated, the IO treated and not start to drop off. If you look at Nadim 2, where they got 6 months, not too long after that 6-month time point, you start to see a little drop off, and it's also true in 671. I haven't noticed. I think the data still has to mature a little bit for AGN, but yeah, it's a tough question.
It's a tough question. I completely agree. I do think that the patients with persistent disease are probably the more interesting to me. Maybe that's because it's more. That's 75% of the patients in these trials. So I think that's the one we really have to tease out and look for better answers. I would like to get more information out of our pathology than just the yes, no, because I think there's more there in terms of the molecular analysis of the tumors, the depth of response, things like that.
Yeah, for sure. Factors like, and so I don't know what's happening at your centers, but our pathology report's becoming quite detailed. With percent residual viable tumor, they'll tell us what proportion is tumor, what proportion is fibrosis, what proportion is necrosis. Necrosis may have some poor prognostic features to it, and so. And then there's also the scenario where you have a complete response in the tumor, but there's persistent nodal disease, which in some studies might be captured as a major pathological response, but might be a poor actor.
Right. I think how we report is going to become more and more important. Someone did ask about MDR and MRD and its role here, and like I said, I think you described it well. It's experimental. It's included and embedded in most of these trials. It is unfortunately not ready for prime time. All right. We have to answer again after this discussion. Goodness gracious. Again, we're trying to make sure everyone's learning. Please answer again quickly. Following surgery for patients, would you consider adjuvant immunotherapy, those with a past CR, those with persistent disease, both, neither, or I'm not sure? I'm sure after our discussion we all got to I'm not sure, right? Which would mean we educated everyone appropriately, I think.
That's right. Well,
Both.
More towards both, yeah.
Excellent. All right. Oops. So I think we're in the open question and answer phase. We have about 4 minutes. I think the only question we kind of didn't really hit to on the iPad, there was one about minimally invasive procedures and, would the ability to do a case minimally invasively drive you toward induction, away from induction? And I guess I do think of, David, those kind of 5-centimeter right upper lobe node negative tumors. Like if you know you can do that with a VATS, are you going to mess that up by inducing someone? And does that change your thoughts?
I can't say that I've had too many cases where it has created a situation where I can't do it by VATS, that I thought I could have done it beforehand. What the problem I've found is that because I'm more and more confident or have a sense that there could have been a good response, I tend to want to progress minimally invasively more, and I'm doing things that I didn't used to do minimally invasively, and it can be very torturous in the OR to know whether this is the time I need to convert or not. Am I compromising the quality of the operation or not? And so I find those decisions currently the hardest to make in the operating room.
The original anecdotal reports were talking about the sort of pseudo-progression and these large nodes and made this dangerous and so forth. I mean, we don't see that very often, but occasionally we will. When you go in to do a VATS lobe, you will, the lesion itself will be smaller, and then there'll be some very beefy large nodes. But what I found generally is they're beefy large nodes, but they kind of splay the PA and everything open, and they're not attached to anything. So in some way, it makes the dissection a little easier when you pluck them out because everything has sort of been pre-dissected for you because of these, and they're clearly large reactive nodes, and it kind of symbolizes a robust immunologic response from the checkpoint agent, and I haven't found that to be a problem, for lobes.
There's also a very interesting question here about the amount of tissue required for evaluation of response to neoadjuvant chemoimmunotherapy. And I think this gets down to sometimes what I suffer with my large upper lobe tumors sitting on the PA. Am I going to do a pneumonectomy for someone who might not have any disease left? I unfortunately don't know that until we have the whole specimen out and in pathology, whether, what kind of response we've really had. I've definitely had the frozen section room yell at me for, saying, I can't tell what this is, so you're going to have to make the decision.
Yeah, I think, it's quite resource intensive for us to send a ton of frozen sections, so on regular cases I don't send a bunch, but on these cases I do, and I find that having some appreciation, nodal response, the patient was node positive preoperatively, and you send a few nodes and they're all coming back negative, that's kind of a guide that maybe there's more profound response in the tumor as well. I don't hesitate to send bronchial and vascular margins much more than I used to because I'm trying to do parenchymal preserving surgery as much as possible. So I think that's something certainly that's changed in my practice.
I'd like to see a show of hands for those of you who have operated after these. How many of you have done a pneumonectomy and had it as a path CR? I certainly have in a number of patients. And
doesn't feel good.
And in my cases, all people who had still persistent large hilar masses that were hard and you couldn't do anything but a pneumonectomy. And luckily, they all done well. But it is a little frustrating to come back then and see them 2 weeks post-op with no disease. Yeah, yeah.
If we get all happy when we do it in esophagus.
Exactly.
Yeah.
So the
Exactly.
comment in the room was that we're all happy when we do such things in the esophagus. Yeah, but it's only the esophagus. It's not like lung.
But no, I think the trade-off is that we probably will be doing more larger resection sleeves, vascular, these things with sterile specimen. So I'm not sure it's a bad thing. I just think it's something we're going to get used to.
But I do like that example, Ara, because I think it's true. We've very much accepted that we cannot tell until the tumor's out in the esophagus, and I think we probably are going to need to accept that in the lung too. It's going to be a long time, I think, before MRD is going to be able to make that for us. All right, we need to end. Thank you all for your participation and your questions. Enjoy the rest of the conference.